and do that right now. Okay. All right. Thanks all for being here. I'm super excited for this session today. My name's Kate Shea. I'm the Senior Manager of Clinical Programs at NCSD, and my pronouns are she, her. Um, a couple things before we get started. This is our final webinar in this series of STI awareness webinar series. Thank you so much to Hologic for our support. And I see a lot more chats coming in, just letting us know where you're tuning in from and what your role is. That's super appreciated. Love to see you introduce yourself. Um, we're going to start out with a quick poll. So I'm going to pull that up now. It's just 4 questions. So please do just take the time to answer these regarding gender affirming care and if you do or do not implement gender affirming care of any kind. And we still have some answers rolling in, but so far, most folks are saying no, they don't currently offer gender affirming care at their organization, and most folks are saying no, they don't feel that transgender or non-binary folks in their community have adequate access to affirming care. And I'm just going to leave that up for a couple more minutes. Um, while you answer this poll, I just want to let y'all know that we will have a bit of time at the end for a Q&A, but we encourage you to enter your questions into the Q&A box. We will get to those at the end, as well as allowing you to raise your hand and come off mute and ask questions live. Any questions that we don't get around to, we will document those and we can answer those retrospectively and send those out. And this recording will also be available after the webinar is live as well. Okay. Looks like most folks have answered. Okay, so I'm going to go ahead and get started here and introduce our speakers. Okay, so Taryn Norman, she, her PhD, has been the Executive Director of Health Outreach Prevention Education, Inc., or HOPE, since January 2021. She believes everyone should have equitable access to non-judgmental healthcare services, and she works through her current role to advocate for this reality. Under her leadership, Hope has added a public health vending machine program and now operates the state's largest syringe service program that helps to reduce the transmission of new infectious diseases. Norman currently serves on the Tulsa STI Task Force and the Oklahoma HIV and Hepatitis C Planning Council. Before joining Hope, she worked for Domestic and Sexual Violence Agency as the Chief Diversity and Equity Officer. She oversaw a team who focused on creating inclusive services for underserved communities. Prior to this, she spent over a decade in higher education teaching composition, gender studies, and literature. Super excited to have Taryn here today. She will be giving us her perspective in Oklahoma, and I'll introduce our second speaker as well, who will be giving us a Chicago perspective. So Dr. Anu Hazra is an associate professor in the section of infectious diseases and global health at the University of Chicago. He is director of STI services at the Chicago Center of HIV Elimination and director of the university's Infectious Diseases Fellowship Program. In addition to his work at U of C, he works at Howard Brown Health, the largest LGBTQ plus health provider in the Midwest. His clinical and research interests center on sexually transmitted infections and their impact on sexual and gender minorities, as well as other vulnerable populations living on the South Side Chicago. These interests are complemented by his clinical work in complex HIV management, PrEP care, hepatitis C management, gender-affirming hormone therapy, high-resolution endoscopy, treatment of opioid use disorder, and medical education. As a clinical ambassador of CDC's Let's Stop HIV Together campaign, he is passionate about equitable healthcare delivery to LGBTQ people of color. So excited to have both of you. I'm going to give Taryn the floor, and I'll stop sharing my screen, and Taryn, you can go ahead and share your slides.
See my slides?
Yes, all good.
Awesome. Thank you. So as Kate said, my name is Taryn Norman. I'm the Executive Director at Health Outreach Prevention Education, or HOPE, in Tulsa, Oklahoma. And I'm really grateful to be here today to talk about how at HOPE we try to use trauma-informed practices to reach underserved communities and create gender-affirming services. So HOPE's mission is to provide health services for hepatitis C, HIV, and other STIs in our Tulsa clinic open to all, and across Oklahoma focused on the most at risk. We incorporated in 1998 and began in the early 90s in response to the lack of resources in Oklahoma during the AIDS epidemic. So creating inclusive services is really baked into the core of our mission and why we started as an agency. So a little context about the climate in Oklahoma then. Last legislative session, we had over 50 bills targeting 2S LGBTQ plus individuals. We had some focused on restricting healthcare access. So we did have a trans healthcare ban pass that bars gender-affirming care services for those under 18. We had a women's bill of rights bill that passed, which creates very limited definitions of what constitutes man and woman. We also, thankfully, had an expedited partner therapy bill pass. And there were attempts to criminalize STIs, which did not pass. So we're kind of working with a mixed bag in Oklahoma. You can never quite tell where the attacks are going to come from and where we will have restrictions and where we won't. And some other related bills, there was a criminalization of sex work and many, many attempts to ban sex education in school systems. So kind of continuing with that theme of operating in a state where there's a mixed bag of laws that increase our access to do the work at the same time that they try to restrict our access to do the work. So HOPE is able to serve anyone 12 and up without guardian consent. For STI services, so not including hepatitis C, that's obviously an area we continue to watch closely and are worried about that there could be future attacks on restricting our access there. HIV education is mandated in schools for once for middle school and once for high school, but it's not really overseen or enforced on any level. So schools do sometimes allow us in and sometimes they don't, but overwhelmingly they ask us to promote abstinence-based education. And in 2021, the state did legalize harm reduction services. So we do see many attacks trying to restrict sexual health access, but at the same time, the state has allowed us to do harm reduction work. Taylor, I saw you hopped on. Did you want to add any context to the conditions in Oklahoma?
I think the only thing to add, hi everyone, Taylor, they, them, I'm with Freedom Oklahoma, is just that the last law that we did have passed in Oklahoma regarding HIV and AIDS was in 1993. So it is very, yes.
Yeah, in each legislative session, we try to mobilize around decriminalizing HIV. but we have not been successful yet. So that's just a little context so that you kind of understand the conditions under which we work in the state. So at Hope, then we try to navigate this climate by implementing trauma-informed practices. Our philosophy and practices really align with these 6 core principles. And we try to take these into consideration, the climate that our clients and patients exist in. So our philosophy then is to meet clients where they are, and we do that in 2 ways. One, by by traveling to those areas where our clients are with our testing vans, and by setting up testing satellite locations with community partners, and then also by providing the services that clients feel like they're ready to receive. So we present them with all kinds of options and choices from which to draw from, and allow them to disclose, where possible, the parts of their identity that they feel safe to, and really just try to create that non-judgmental, supportive environment. So we offer lots of different options for ways of testing and receiving testing, which helps us to really expand to those underserved communities. So some of the strategies that we try to employ are using visual clues in our entryway, in our waiting rooms, having diverse representation on our materials and our brochures, putting up pride flags during Pride Month, really any kind of markers that immediately allow our participants to see that they are in a place that recognizes and supports them. We also have gender neutral restrooms at the front and all throughout the building. And then on our intake forms, we allow clients to select a preferred name as well as a legal name. So we ask them, what name should we call you? We ask them for pronouns, and we ask staff to reciprocate, sharing their pronouns to build that rapport. And we also provide a range of gender options and space to add an alternative gender identity if they don't see their gender represented in that list that we have provided. Language is always evolving, so we want to acknowledge that and create space for that. And all of these strategies really help us to build that rapport and trust and help us to destigmatize. Again, recognizing that a lot of our participants are coming in with really negative experiences, that they've mostly been isolated from mainstream medical systems, and those interactions they've had with mainstream medical systems haven't always been affirming. So continuing along then with the theme of non-judgmental language, we try to use language that doesn't make assumptions about sexual activity based on how someone presents or how they label themselves. So here are a couple of examples of that type of language that we would use. Are you sexually active with one partner or more than one partner? Do you have outside partners? Who do your partners have sex with? What types of sexual activity do you have? Tell me about the type of sex you're having. Tell me about how you use protection or barriers. Are there times when you don't use protection? And tell me about those. So again, we're really taking out here any labels, any assumptions about sexual activity, and creating space for our clients to disclose what they feel comfortable with. So we know that many clients may be nervous to disclose due to bad previous experiences and fears about how data and information that they provide to us will be used. And I'm sure many of you do have to report data to the state. So our clients know that, and they often are nervous about sharing information because they don't have control about where that data goes. So an example would be, in Oklahoma, we have a lot of faith-based organizations that do have rules around who they will serve. And so when we go in to do HIV and hepatitis C testing, on site at those locations, you can tell that many of the clients are nervous and reluctant to tell the truth about their sexual activity because they're worried that that information will then be released to the community partner, who then might kick them out of services because of how they identify. So we really try to support our clients by helping them to understand how the data will be used and how we function in relation to the community partners that we work with, so that they know their rights, they know that their information won't be provided to our community partners, but that it will be submitted to the state for disease intervention specialists. So to the best of your ability then, we always encourage our staff to be transparent about why they're asking for information that they are and how that data will be used. So what data will stay internal versus what data will be shared externally, and how that data will be shared. And really try to ask ourselves, like, what information do we actually need for testing? Where can we push back perhaps on funders who might be requiring information that we know is going to make our clients nervous to disclose? And like, what information do we need for medical treatment versus other needs they might be coming in for, such as accessing supplies or testing? Taylor, I wanted to pause here as well and see if you wanted to talk about anything in this section.
Yeah, I think just to kind of add to what you were already saying is that I know in Oklahoma specifically, our state is working to build lists and use the data that is being provided as an opportunity to then discriminate and cause issue for people who are part of the 2S LGBTQ plus community. So really knowing what can remain anonymous and what is going to be tied to an individual is important when you're navigating 2S LGBTQ plus identities and data.
Yeah, it's tricky because we all do operate within systems, and we have certain data that we need to collect for those systems and for funders. Excuse me. And we can't necessarily control how outside agencies are going to use that data and respond. So I think just being really open with clients about that and helping them to make informed choices about what they choose to disclose and what they choose to not disclose. So we really try to bring in our community that we're working with to get their impact, their feedback, to make sure that we are having the right impact. So I think a really important lesson that we have learned, particularly with our vending machine program that distributes sterile syringes, we have not advertised that program, and within a year and a half, it has over 3,000 participants enrolled in it. And that is because clients will share with other folks who need those resources about us. So word of mouth, recognizing that our clients will share positive experiences and share negative experiences is, really important for us to keep in mind. And then making sure that we create opportunities through focus groups, through surveys, for them to further share their experiences and help us to guide and direct, because we know that our community's needs change all the time. And what we think might work, even though we have many staff with lived experience in this space, isn't necessarily what's going to actually work right now. So we try to have our create opportunities for our participants to share their perspectives. I think another point I want to talk about here, which I'm sure a lot of y'all have experienced with changes happening in more conservative states, that when you hire folks with lived experience, it can be really hard to retain those staff members when the state then passes legislation that targets their existence. So we have seen quite a high turnover with some staff who have chosen to move out of state in order to live the kinds of lives they want and to have access to the services that they need to be healthy and to thrive. I think it's also really important to think about how we are promoting healing and recovery through the stories that we share. Many of us have probably been to fundraisers where sometimes it feels like people are taken advantage of when they share their stories because it really emphasizes the harm that's been caused. So we really try to lift up our clients' healing and recovery and support all of their and celebrate all of their successes. We are trying to increase peer services in-house through providing peer navigation. That's something that we're aspiring to do that we haven't achieved yet. And then through that work, we also hope to add some peer support groups. Again, it's really important for our communities to be able to share their stories with others who have gone through similar experiences and share resources. So again, in thinking about ways that we can hear from our community and our clients, we do run a lot of focus groups, participate in community advisory boards, use a lot of surveys to really try to make sure that we are getting feedback on what's going to work for our clients right now and their needs in an effort to try to share in that decision-making power. We really emphasize the importance of clients setting their own goals and priorities. And while we have a whole list of services, we know that many of our clients aren't ready to receive some of those services. I think a good example we often run into is vending machine participants who are accessing our sterile injection supplies, who know and have known for quite some time that they have hepatitis C. But they're not ready to receive treatment for that. And so, we allow our clients to really direct their own healthcare journeys and share about the resources that we have and let them know that we're ready to provide those resources if and when they choose to do so. And we do try to partner authentically with organizations that clients already trust. Some of that we have to balance with the realities of just where clients have to go to get the services that they need. Kind of going back earlier to my comments on faith-based organizations in the community that we work in, and that a lot of our clients who are using those resources don't necessarily identify with the missions of those organizations, but that's their only opportunity to receive services. So it's a balancing act. And then we really try to emphasize destigmatizing language. So this last point on here, what happened to you rather than what's wrong with you, going back to that trauma-informed approach. We try to be so thoughtful and careful about how our clients have experienced the world and how they will be coming into our space, and give a lot of grace to them, because we know that they might not trust us yet, and they've probably had experiences with other entities that have really eroded trust in medical systems. So using that destigmatizing language, and again, really letting clients drive their own journey. Asking them what's worked for them previously, and not again forcing all of the services that we have on someone, but educating them about what their options are and letting them choose from those options. And then in terms of thinking about how to support your staff, I think it's really important to build in annual trainings. We'll often have DEI trainings once now and again, but it's with staff turnover and making sure that you keep up to date with changes in language, changes in best practices, like really building in annual trainings that focus on key concepts and terms and that evolution of language, the history of identity and the impact on sexual health service access, social determinants of health that affect particular populations, and creating opportunity for staff to learn about medical traumas, because all of this impacts the way that clients show up, and it also impacts the way that our staff show up and how they provide services. And all of this training helps to build culturally responsive skills so that we can mitigate the impact of biases that our staff show up with. So if we know that clients are coming in and they may be reluctant to identify their sexual practices because of previous negative experiences when they've done so in other settings, we have to also recognize that sometimes our staff will show up and make assumptions, right? So helping to educate your staff to mitigate those impacts and recognize that just because somebody identifies a certain way does not then mean that they only engage in certain kinds of sexual practices, because that then creates missed opportunity to educate our clients about all the kinds of services that might actually be useful to them. Okay. Taylor, did you want to jump in and add anything? I feel like I got through that really quickly.
No, you did great. I mean, the friendly reminder, obviously, that the 2S LGBTQ plus community is not a monolith, but I think that we all here know that. But just to keep it in forethought as you're figuring out what your path is, to make sure to show up for that community.
Thank you so much. And thank you, Taylor, for chiming in as well. I appreciate you being here. Thank you, Taryn. Really appreciate that. And Anu, we'll pass it over to you.
Excellent. Thanks so much. A lot of excellent work you all are doing in Oklahoma, Taryn. It's awesome to hear. And pull up my slides.
And just while Dr. Hauser's doing that, please do add any questions to the Q&A or to the chat, and we will get around to them at the end for our Q&A session.
Excellent. Thanks, Kate. Appreciate it. My computer is being a bit funky, so I'm gonna turn my camera off in efforts to save some bandwidth. But I am so happy to be here to talk a little bit about some more clinical aspects of care for gender-affirming STI services in general. Briefly, I was hoping to spend today talking a bit about the landscape of STIs, which I don't think is anything new to all of us here on this call, but then really honing in on the specific sexual needs of transgender, gender diverse individuals, reviewing some current screening recommendations and published protocols, as well as biomedical prevention strategies for both HIV and STIs, as they pertain specifically to trans and gender diverse folks, and then identify barriers and propose solutions to improving access to sexual health services for this priority population. So again, we're not, none of this is new at all to us working in the field. We know that, we are seeing rising rates of bacterial STIs across the US and across different segments of the population, with most concerning rises in cases of congenital syphilis, which remains a public health priority as well. And we know that, 1 in 5 people in the United States on any given day will have an STI. And we see that although STIs have increased around all populations, that are certain marginalized groups are disproportionately impacted by sort of the explosion of STIs. And that includes young people, women, LGBT individuals, transgender diverse individuals, as well as Black, Latinx, and American Indian and Alaskan Natives. And we know this isn't cheap, and all of us who are working in our different health departments understand the cost of the problem to the U.S. healthcare system. We know that medical expenditures associated with STIs are approaching about $16 billion a year, with obviously long-term effects of STIs, including infertility, miscarriage, or newborn death itself. And despite all this, we are seeing sort of flat funding from the CDC and federal funders in terms of helping mitigate this epidemic. And this is, again, a graphic I think that has been circulating quite a bit, looking at funding, a line item from the CDC STI prevention budget, which has remained sort of flat in the teal there. And when you adjust for inflation and population, you see that our actual spending power has decreased by about 50% in the past 20 years, while in the red line you see sort of syphilis rates continuing to rise. And, I think we understand that STIs cannot be separated from other sort of ongoing conditions that track along these lines. And so we know that, the epidemics of STIs, HIV, substance use disorder, Mpox, all this are really challenged upstream with things like systemic racism, homophobia, transphobia, housing, which really, create this syndemic and understanding that, these syndemics have an increased synergistic impact on affected communities. And really, if we're looking to create solutions and trying to control STIs in a certain population, we have to be looking at the population as a whole and understand what are other social determinants are being impacted here, and understanding that's not just STIs, and that STI control and HIV elimination, for example, go hand in hand. We can't eliminate HIV without controlling STIs, and vice versa. And I think this all comes down to sort of our current outdated sort of sexual health framework. Our nation's response to STI has been largely focused on individual risk factors and individual behavior changes. And this really approach fails to address sort of structural and societal factors that, affect both infection and disease. And instead, this type of approach really fuels stigma and shame, and particularly even more so in marginalized communities like trans and gender diverse folks. The clinical focus on the current STI control really primarily is talking about the harmful impacts on women and children, with little focus on men and other individuals and their role in potentially transmitting STIs in general. And the holistic approach that focuses on sexual health in the context of broader health and well-being truly is needed. And the WHO, came out with this statement nearly 20 years ago. And I think this was, transformative when we think about how it relates to STIs, understanding that sexual health is just not the absence of disease and dysfunction, that when we think about sexual health, we need to think about it in a holistic lens, and particularly in the context in which our populations live and have sex. And that we can't just think about, my patient does not have syphilis and therefore they're healthy. It's important to recognize that there are other factors that may be important to that patient besides just an STI screening test that needs to be taken into account when thinking about their sexual history. And so really, in general, this is from the National Association of Sciences that came out with sort of a key paradigm shifts that are needed in STI approach to STIs about a few years ago. That new approaches and strategies that specifically engage men, strategies that improve sexual health, that address the needs of priority populations, and expanding attention and resources to underserved populations, including Black, Latinx, and Indigenous populations, as well as those who engage in sex work, transgender and gender diverse folks as well. So let's talk about transgender and gender diverse folks. We know that there's key, sexual health concerns of this population. We know that there's barriers in accessing appropriate and affirming health services. This is a snippet from the 2015 U.S. Trans Survey, which really shows negative experience or prevalence of negative experiences of transgender respondents in seeking a healthcare provider in the past year. Again, none of these experiences are new, and I think many of our trans patients who have come to us with sort of these this type of story coloring their health history as well. We also see higher rates of sexual health issues and disparities in care compared to transgender populations, cisgender populations, and increased vulnerability to STIs and HIV. Again, when we think about these barriers to accessing healthcare, we think about these structural barriers, lack of, insurance coverage, denial of health services, mistreatment by health providers, and provider discomfort or an experience. And I would sort of add to this from, just the last half hour's talk, now increasing structural legal barriers that are impacting trans folks' ability to even receive general care, let alone sexual health care itself. This all leads to health disparities. So, we talk a lot about, the higher prevalence of HIV in transgender women in the United States. And I think it's important for us to always take a step back and realize that being trans by no means makes someone more susceptible or vulnerable to HIV. It's how society treats you for being trans that increases your vulnerability to HIV and sort of other communicable diseases. And so, we see sort of, transgender women with an estimated prevalence of 21.6%, significantly higher than the general population of 0.3% itself. Transgender men, this is, obviously, really, I think the caveat is we have such a lack of data in transgender men, which is a whole other issue that I'll talk about. But, an estimated prevalence of 1 to 4%, but still significantly higher than our background rate here in the United States. And we know that even within transgender populations, there are intersectional identities that are disproportionately impacted, which include Black transgender individuals who experience higher rates of HIV infection compared to their white or Hispanic trans counterparts. And these disparities sort of highlight the need for targeted prevention and care strategies for these populations. Again, going back to understanding sort of the social determinants of health that impact someone coming to your clinic's vulnerability to HIV and thinking about them in that way. Then there's challenges in STI data and reporting. A lot of us here are, in charge of reporting our STIs to the state or to the CDC. There's limited data availability, so outdated and often inadequate reporting metrics fail to capture the full scope of STIs in transgender individuals. There's still several states that will not collect data on gender identity among their trans populations. That leads to, again, data being inaccurate or lumped together in a faulty way, and us not really being able to really pinpoint or really think about the true prevalence or vulnerability among transgender folks. And this again goes into thinking about resources and whatnot that would be utilized, but then also you can't assess disparities and equities if you don't count people. And so if you're not able to actually count them and actually think about and accumulate that data, there's no way for us to really think about comparing or even thinking about improving health outcomes. And the CDC's updated treatment guidelines in 2021 did recognize transgender and gender diverse populations as a key group that required enhanced services. And in their guidelines, they did talk about some clinical care aspects or screening aspects that I'll get to in just a bit. But in general, these challenges in STI reporting really impede the development of effective public health strategies and patient care initiatives. Again, if you don't count people, there's no way to create any change if you can't actually see the disparities there. So, when we think about HIV screening specifically for transgender populations, regular HIV screening should be offered to all trans folks with frequency based on personal vulnerability and sexual behavior. And so really thinking about folks who are sexually active to be having an HIV screen at least every 3 to 6 months. And again, folks who are not sexually active, making sure and have no other vulnerability to HIV to make sure that they at least have a lifetime screen of HIV, just like their cisgender counterparts. All sexually active trans folks who are, not living with HIV should be counseled for pre-exposure prophylaxis as a preventative measure. And we'll talk a little bit about the different options of PrEP and how they pertain to specific trans populations in just a bit. When thinking about STIs, the recommendations for the CDC is to extend the current recommendations for chlamydia and gonorrhea screening in all sexually active women under the age of 25 to include transgender men, non-binary, and other non-binary individuals assigned female sex at birth. The other important thing that was noted in the guidelines is extragenital testing. I think, many of us are aware that, extragenital testing is really crucial when thinking about any sexual and gender minority or really anyone who has sex. Understanding that a urine gonorrhea chlamydia test will not really tell us at all what might be going on at the rectum or the oropharynx. And really making sure the recommendation to implement nucleic acid amplification testing like we do for all other individuals for gonorrhea chlamydia at the anatomical sites that are relevant to the patient's sexual practices, such as oral, anal, and neovaginal sites. There was some controversy about whether or not to screen neovaginas for gonorrhea and chlamydia. I will say, from our practice, we have diagnosed bacterial STIs in neovaginas, and those areas can oftentimes epithelialize over time and become almost close to a mucosal surface, which again can increase acquisition for these bacterial STIs. And so you should be able to swab them and send them off for NAT testing in general. When thinking about asymptomatic individuals, obviously thinking about STI symptoms, to be aware of common STI symptoms and ensure appropriate screening, even for those who don't have symptoms. And again, adjusting testing based on sexual practices and anatomical sites used for sex, which really goes back to why getting a really comprehensive sexual history is so important here. A few words on cervical swabs, for transgender men and non-binary folks assigned female sex at birth who have a cervix and engage in frontal sex or vaginal sex, there is clear data that cervical swabs are more effective in detecting bacterial cervical infections than a urine specimen. And so again, these can be obviously self-collection. These do not need to be provider collected, but it's important to recognize really swabbing the site of sex itself. It tends to be much more sensitive and specific than a urine specimen in clinic. And then let's move on to some biomedical prevention strategies. So, when we think about HIV pre-exposure prophylaxis, again, I think the majority of a lot of our labeling and thinking about our messaging has really been focused on men's sex with men and to a certain degree transgender women. This is showing sort of the different options of PrEP we have both here in the US, but also globally, which include daily TDF-FTC or daily Truvada or generic Truvada, on-demand TDF-FTC or on-demand Truvada or generic Truvada, on-demand TAF-FTC, daily TAF-FTC or daily Descovy, and injectable cabotegravir or Apretude. And then lastly, Daptovarin vaginal ring, which is approved elsewhere in the world, but not available in the United States. So I won't speak to that too much. For daily TDF-FTC, it can be used for all populations. It's and recommended for all populations. And so this is a great daily oral PrEP option that you can use for all of your trans patients in general. In terms of on-demand TDF-FTC, understand that the actual WHO guideline recommendation is really only in MSM. The IAS USA recommendation is in both MSM and transgender women and heterosexual men. But no, this is extrapolating from data from the clinical trials, which was only looking at MSM itself. And currently, we do not have an on-demand option for anyone assigned female sex at birth. So when you think about PrEP in those patients, really all you have is a daily oral option in general. The same thing with Descovy for PrEP. So daily Descovy, has been FDA approved for use in all folks assigned male sex at birth, but again, not approved and no change in label for folks assigned female sex at birth itself. And then lastly, injectable cabotegravir or Apretude is, I think, important to recognize that these clinical studies really centered sexual and gender minorities in both their HPTN trials. And because of that, we have been able to have sort of guideline recommendations and FDA approval in all populations. And it really goes down to making sure that we're creating inclusive clinical trials in the future as well. But injectable cabotegravir can be used in all individuals, regardless of gender identity and the types of sex that they have. And then I did want to spend a little bit of time talking about DoxyPEP as another biomedical prevention strategy. And I think that intersects really a lot with our own STI screening mechanisms in general. We know that doxycycline post-exposure prophylaxis has demonstrated significant reduction in bacterial STIs among cisgender men and transgender women who have sex with men. Data on doxyPEP's efficacy in cisgender women, transgender men, and non-binary individuals behind female sex at birth is limited and still in the works. And again, advocacy of future research specifically in these populations that have been left behind is really crucial. This is the data to date that we have in the multiple clinical trials looking at doxyPEP. We have the initial trial in Paris looking at just at HIV negative MSM, saw a 47% reduction in first chlamydia or syphilis infection and no difference in gonorrhea. Again, doxyPEP is defined as taking 200 milligrams of doxy within 24 hours, but at least 72 hours after condomless sex itself. So that's the dosing for all of these doxyPEP strategies. The doxyPEP trial here in the United States was looking looking at both MSM and transgender women, both living with HIV, as well as those not living with HIV, but on PrEP, and saw a 66% reduction in first-time STI of gonorrhea, chlamydia, or syphilis in about a 10-month period. The one caveat here is while they did open this trial to transgender women, less than 5% of the participants did identify as trans women. So again, it was a heavy cisgender male study itself. The French had their DoxyVac study, which is again looking also at a larger cohort of HIV negative MSM and saw a reduction in, again, chlamydia, syphilis, and gonorrhea. And then the one trial done in cisgender women was the DPEP-KE trial done in Kimusu, Kenya. Nearly 500 cisgender women not living with HIV on PrEP saw no reduction in any STI in those that got DoxyPEP and did not get DoxyPEP. It's important to note that there were 4 social harms reported in the DoxyPEP group amongst these women, all which were related to unanticipated disclosure of taking doxycycline for STI prophylaxis. Recent hair sampling and other adherence measures really calls to question the potential adherence to DoxyPEP among the women in the DoxyPEP group that again would impact its efficacy. And then most recently in Munich this past summer at the AIDS conference was looking at the DISCO study in Canada. This was a doxy PrEP study, so a daily doxy study in a small number of MSM living with HIV. Did see reduction in syphilis, chlamydia, and gonorrhea. So how do we put this all together? Well, since all these data have come out, several both national as well as local and state health departments have released guidance around DoxyPEP. And this is all culminated to the CDC recommending their guidance, which specifically names transgender women with MSM as a priority population to be considering DoxyPEP. With this, they also recommend routine STI screening and again, patient-centered sex and really STI and sexual health counseling important. They do talk about that they don't say that cisgender women, transgender men, and other queer non-binary persons cannot be given DoxyPEP, but they say they cannot make a recommendation about DoxyPEP in this population at this time. So this leaves room open to be thinking about potentially maybe your trans-masculine patients who have sex with men and are vulnerable to STIs to be thinking potentially of DoxyPEP for them. We'll be presenting some data at the CDC STI Prevention Conference later this month on some of our centers' experience with prescribing DoxyPEP in people assigned female sex at birth. In the end, it's really important to be integrating our services for optimal care. Again, I think we understand the logistical barriers and systemic obstacles in front of our trans and gender diverse populations, that even getting into a clinic or getting through a clinic door often means significant struggles and sacrifices they've had to make. And so once they're here, we should be thinking about co-location of services. We shouldn't be splitting apart where someone gets their hormone therapy from, where they get their HIV PrEP from, and where they get their STI screening from. Ideally, they would be housed in one location where they're able to provide comprehensive wraparound sexual health care simultaneously. Like all of our patients that we work with in our sexual health clinics, thinking about a trauma-informed approach that acknowledges and addresses the unique challenges faced by transgender and gender diverse individuals is so important. And then really understanding the benefits of this includes improved access to necessary services and enhancing patient comfort and continuity of care. And in the end, from a public health standpoint, reducing incident infections and communicable illnesses. When we think about addressing disparities and ensuring access, implementing policies and practices that reduce health disparities and health access and outcome for transgender individuals is so important. Supporting initiatives that promote equitable healthcare policies and funding for trans services is equally important. So the work that the Hope Clinic is doing, I think, is really instrumental to this type of cause, both on an individual level, but also on a legal and policy level as well. And again, working to create sort of these inclusive environments that address the specific needs of transgender and gender diverse individuals is so important, because if you're a health system that is not working to create an environment that attracts or brings together trans individuals, you will never be able to serve them. And there's clearly areas of future research that needs. Again, only until recently have transgender individuals have been a population that are being actively recruited in both HIV clinical trials as well as STI clinical trials. We need to expand research that includes that deliberately and consciously includes transgender populations to address gaps in current knowledge. So, it's heartening to see that, newer PrEP trials, including that for cabotegravir, but also for lenacapavir, are having specific trials looking and recruiting transgender and gender diverse individuals. We need to see that same type of effort and energy in our sexual health and STI trials as well. To date, there is not a single doxypep trial looking at transgender men. There's not a single doxypep trial looking at non-binary individuals. Without looking at and doing this type of research, there's no way for us to ever be able to provide these resources in a really informed way for our populations. And again, encouraging policies that support comprehensive data collection and addressing health disparities is so important. So just in summary, I think, it's integral to address the significant health barriers to sexual health services for transgender individuals, understanding when someone comes again to your clinic or comes for an STI screening that they've went through a lot to get to where they are right now. And it's really it's your responsibility to make sure that they're receiving the care that they deserve. Being able to implement and advocate for effective screening and preventive strategies, focusing on a comprehensive trauma-informed approach to sexual health care as a whole, and emphasizing the need for ongoing advocacy, research, and policy development to improve sexual health outcomes for all transgender folks that all will trickle down to what goes on in the exam room as well. I know that was fast, but I'm happy to take questions with the rest of the group right now.
Thank you so much, Dr. Hazra. Yes, we will move into the question portion. Looks like we have one to start in the Q&A box. Otherwise, please do type in if you do have a question, or you can use the raise your hand feature, and then we can unmute you so you can ask it live. This first question here is, do you have any data to show how the syringe service vending machine affects STI burden in the community?
That's a great question. I think it's early days. We do have to register with the state to do syringe services, and they are collecting data. There's an interim study happening this summer on the impact. But I think we know anecdotally it's helping to reduce community transmission. But honestly, I would say, like, as an agency, measuring those long-term outcomes and changes in behavior and reduction in rates in the community, it's hard to find funders who will fund those long-term studies for us. So sorry, I know that's not a great answer, but hopefully we will have some data soon.
Yeah, thank you. Thank you, Taryn, for answering. Anyone else have any questions? Ooh, 3 digital vending machines being to distribute free condoms and lube in Dallas. That's awesome. Okay. Allison has a question, so I'm gonna unmute you.
Thank you. Hi, my name's Allison, and I work at San Francisco City Clinic, which is our Department of Public Health sexual health clinic. And we see many trans folks. And recently I saw someone, it brought up for me, like, how we identify people, like in their medical chart and in the note itself. For this particular patient, like, she's a trans woman, but identifies as female. And like, when I was looking, I always like preview someone's chart to think about like what testing they're going to need, what health concerns might be. And she was identified as like sex and gender was female. And then in the note, some people referred to her as a female, some people referred to her as a trans woman. And it was just interesting to me, like, maybe I knew in particularly like what your thoughts around how we identify patients and best practices.
Yeah, no, I think that brings up that's an excellent point. And I've seen that happen at Howard Brown as well, where, someone has their entire EMR is woman, is female, or she her pronouns, or however we have. But then the way people are documenting their identity or her identity is as document as transgender women, and some just woman. And I do think there is some it makes me feel a certain way, because I feel like we're still separating folks in a way. And I would say, unless there is something intrinsically about that encounter that has to do with their trans identity, that simply, saying that patient is a woman is all that's really is needed. And that's what, at least the practice that we like to promote in our clinics. Obviously, if they're coming in for, a gender affirming hormone therapy visit or whatnot, their trans identity is important or relevant to that encounter. But just like how we in medical communities have now moved away from saying this is a so and so year old Black woman, or like, identifying race in that sort of in notes. I think thinking about cis and trans in that same way, or I have been thinking about cis and trans in that same way, that I would only really invoke that or think about that unless it has something to do with the actual visit itself. But I think that brings up a great point, because I don't think there are like clear best practices around this. I think, we've talked about collecting pronouns and making EMRs like more inclusive, but no one's actually talked about what are the best practices of how we address and document this, particularly in the age of open medical records, where our patients are seeing our records as well. So it's a really great point, and I think everyone is going about it in a piecemeal fashion as well.
Thank you. I appreciate that.
I just wanted to add to that as well, that I think that when you think in the context of staying gender neutral, that's actually most gender inclusive.
Yeah.
And when you hearken it back to anatomy and making sure that you are serving the need of whatever that appointment is, you're not going to have a conversation about gender. You're going to have an individualized care plan for that patient. And if you work that into as your best practice, then you're going to like have the best care.
Thank you, Taylor. We do have a question in the chat. How is the Midwest, Chicago/Iowa perspective treating this topic compared to other places in the US?
Yeah, I mean, the topic in terms of like trans health and transsexual health, I'm assuming.
I'm assuming, I'm not sure if that person wants to go
Yeah,
off
yeah, Lucy said
mute
yes.
or
Okay, yeah,
expand.
yeah. No, I think Chicago and even Illinois as a whole has remained this kind of island around the Midwest that has been a place where people have come for gender affirming care and sexual health services. I think there has been specifically in Springfield changes to the Illinois Constitution to really enshrine, access to healthcare for transgender individuals of all ages. And so I think I think it remains a haven here, and where I tend to see patients a lot who have traveled from Indiana to see me, or virtually, or whatnot. And I know there have been several clinics set up in downstate Illinois to be now servicing Missouri, which has been having increasing sort of attacks against trans care, as well as other states like Kentucky and the such. But yeah, no, I would say from a Chicago perspective, it's been at the forefront of what we want to protect and sort of enshrine in terms of access, which obviously has an impact on the surrounding Midwest as well.
Thank you so much. Stacy, I'm going to allow you to talk. Okay, go ahead.
Thank you. Yeah, I have a question for you all. I work at a local health department, and I work specifically in HIV prevention, but we're trying to write our grants so that we're requiring our funded programs to not only do HIV prevention and STI prevention services, but we want to include those wraparound services like you were talking about, including gender affirming care. But our budgets are just getting shorter and smaller and smaller. So just wondering if you had any recommendations for how to include gender affirming care on a limited budget.
So, I mean, there's obviously strategies that have been implemented by a lot of places. I mean, if you have the ability to have if the site or the health system has a 340B pharmacy, we've often used the 340B pharmacy pricing for hormones that have been able to be improved. But I also understand that that's not a reality for the majority of the United States in terms of access itself. Um, yeah, I mean, I think at the very least, if your sites that are competing for RFAs or whatnot are at least able to collect data on transgender individuals, if not, they're not able to provide the actual care because they don't have the resources to, but to be actually making sure that they are an affirming place and can prove that to you. I think that's also really important. That takes very little in terms of physical cost in general, but strategically, we've seen, we've been able to cover often the cost of estrogen, testosterone, and whatnot through some of our 340B drug pricing programs, which are often really run through and kept afloat based on our treatment and prevention options for HIV.
Yeah, I think in Oklahoma, we've just faced so many restrictions over the last couple of years that and Taylor can probably speak more to this, but we just have a shortage of providers who are still left in the state to provide gender affirming care. Yeah, I mean, a lot of folks are just leaving because they can't do the work that they want to do here.
Thank you both. And just to sort of wrap up and add to a point that Taylor made in the chat, they said a tactic we have used for gender affirming care is partnering with other orgs and collaborating to pool resources, which I think is a really great point. So I'm wondering if each of you, just as like a closing point, could end if folks in the audience are looking for like a first step in more gender inclusive practices, what would each of you recommend as a starting point?
Well, I think it's important to make sure that whoever's making the decisions reflects the communities that you have to serve. I think that's like an important thing, regardless of what you're trying to do. So if you're trying to, create a practice that is more gender inclusive, then whatever team that you put together needs to include transgender, gender diverse folks in it. And that could be employees, but it could also be community advisory boards and other folks in the community that can tell you what's going on. I find, that to be the most as a cisgender individual who does work in trans communities, just sitting and listening to their needs, and it's often surprising how divergent you think their needs are, or what versus what their true actual needs are itself. And oftentimes these changes are not massive changes to your building. These are just simple changes, like even Taylor is putting in the chat, which are easy fixes and don't cost a thing. But oftentimes we would not even know that from a structural level had we not really had community input in the work that we do.
And jumping off of that, I would say finding those community partners, particularly if you do exist in states that are really restrictive, finding your allies, like your support groups, bringing in those diverse points of views, because it can be really hard work. And I think Hope and Freedom Oklahoma and other local partners have had some really great success supporting each other's work, sharing resources, but then also coming at problems from different angles. So we've been pretty effective tackling those, like I said, problems from different angles.
And Taylor, I know you put something in the chat, but I want to make sure you don't have anything else to add before we close out.
No, partnerships was definitely going to be my answer, but just to add, so we're having more suggestions. It can be difficult, especially if you're nonprofit based, but really sitting down and putting dollars to trainings so that your staff can be trained and it's not an add-on service or something that is voluntary. Like it's part of your training, it's part of the work that you're doing, and you're integrating it into your policies and practices.
That's a great point. Thank you so much. Thank you all for being here. Oh, I'm sorry, there's one more question if y'all are okay with answering. How do we ask for community feedback without having additional burden and ask from the folks who we are trying to serve?
That's what I was gonna say, pay them.
Pay them.
Has to be a line, has to be a line item in your budget. No one, you should, yeah. Marginalized folks in general should not be the ones in the backs of free labor in general. Yeah.
And if you don't know where to start, like if you just don't have a starting place because like trans and gender diverse communities aren't where your work has been, you have to, there's some sort of grassroots organization, there's some sort of state serving organization, like that's Hope and Freedom Oklahoma. Like we partner in that way. There's some organization in your city, in your state that does equity work for trans and gender diverse people, and that can be your starting point to figure out where to go from there, but absolutely pay them.
Awesome. Thank you so much. Thank you to our wonderful speakers for being here. We appreciate the work that you do and you just sharing your work. Really impactful just to hear your work in this field. Just a reminder, we will be offering this recording after the fact, and feel free to just send us an email if you have any additional questions or need additional support or resources. Thank you so much to everyone for being here, and have a great rest of your day.
Thanks so much.
Thank you.